First, Dr. Hammond, thank you for joining us. You were born and raised in the community where you now deliver healthcare. Share with us your COVID-19 story and how you had to think differently about providing care.
Thank you, Dr. Gilkey. Good morning and welcome, everybody. Um, as you mentioned, certainly have had to shift working in primary care. Before COVID, as the medical director here at Mercy, I was responsible for the oversight of 7 primary care locations, from Yarmouth to Gorham, South Portland, Portland, Wyndham, and at each of these locations, we would see over 40 patients a day for regular primary care needs and concerns, well visits, acute visits, injuries, etc. In addition, we had 4 walk-in care locations located in Yarmouth, Wyndham, Gorham, and Westbrook. These locations would see over 1,100 patients per week, and would not only take care of Mercy primary care patients, but open to the public and take care of anybody from another healthcare organization, or patients who did not have a primary care provider. As March came about and we started to look at COVID, our operations had to shift very dramatically. March 12th was the first presumed COVID positive patient in the state of Maine. And starting just the week prior, a small group had gotten together to talk about what the impact was going to be for the state of Maine and for us here locally. Within a very short time period, we knew that we had to jump on board and be prepared for what was coming, and immediately developed 4 of our testing site. Our tent was the first to open on the March 16th, and able to have workflows in place where patients could call, initially patients who were having symptoms could call our triage hotline and have an appointment where they could drive through the tent, have a COVID testing swab obtained, and drive out, all done within less than 5 minutes. Um, as we were excited about that tent opening, and being able to provide services for the Cumberland County, Southern Maine area, we knew that we had to jump right into the next step. So approximately 7 to 8 days later, we opened our next level of COVID care, which was a Westbrook respiratory tent. So using the walk-in care resources, staff, and some supplies and workflows, we started to be able to offer physical exams. So patients who not only had symptoms, but maybe had an underlying condition or needed more than just a test or more than just a phone call supportive care, they actually needed to be seen. They needed to have their vital signs assessed, their oxygen level assessed, their lungs listened to, perhaps a chest x-ray. And so on the 24th, we opened the Westbrook Respiratory Tent. Finally, during the peak of Cumberland County, when the emergency rooms were very busy, primary care offices were all having to make adjustments on how to take care of patients who had potential respiratory illness and not bring all of those patients into their office, having to protect other patients, having to protect staff and employees. We also developed a COVID virtual clinic. So the COVID virtual clinic was able to do assessments of patients over telehealth, either phone call or video appointment, and allow additional assessment. The virtual clinic was able to support patients who had been to the emergency room. They were presumed COVID positive or tested COVID positive, but they didn't need an admission. They maybe didn't have a primary care provider, so they had no follow-up available to them. Our COVID virtual clinic was able to reach out to them 24 to 48 hours after leaving the ER, provide them a nursing level support, and then, if necessary, connect them with a walk-in care provider who could give them the next level of care. So over the course of a couple weeks, we were able to implement 3 different levels of COVID care using some of our resources from primary care, walk-in care, and really having to adjust to what was happening here in our community. To date, we've seen over 3,500 patients through our testing site, and over 1,000 patients who have been assessed at the ambulatory respiratory site. We're sitting in a place now where there's a lot of trepidation with returning to school, returning to work and what that means for all of us in our community. As we look at that in primary care, we have to take all of those things into account. How do we continue to provide not only COVID respiratory care, but return to take care of chronic conditions, diabetic patients, well visits, things that maybe have waited for the last several months. And we know in order to do that, we need to protect not only our patients, but also our employees. So we've done things like have screening at the front door, temperature checks, separating those who are sick from those who do not have fever, respiratory concerns. We're trying to help our patients by having less waiting time, fewer chairs in the waiting rooms to allow for more comfortable wait, but really focusing on getting patients to the exam room as soon as possible. And we can do that by registering them on the phone, getting verbal consent, and so that when the patient arrives at their appointment, they can be taken right to the exam room whenever possible. We're also looking to find our balance about telehealth. We can provide quality healthcare with a video on many occasions, and so we do need to find a balance about what is appropriate for patient to come in person, and when is it safe to do so, and where is it safe to do so, and what we can do to meet patients what they need, potentially in their own home with a telehealth appointment.
Great. Well, thank you, Dr. Hammond. Ben Waxman, it's a pleasure having you join us. Your company's mission is built on trust, respect, and doing what's right for your employees and your community while creating quality made in the USA apparel. Many of your employees are immigrants. Share with us how your experience with COVID-19 unfolded. Ben, you need to be off of mute.
Sure. Thanks, Dr. Gilkey, and thank you for having us today. My wife and I, Whitney Waxman, own American Roots. We founded it in 2015 with a purpose to create good paying jobs, produce 100% American-made and union-made gear, from sweatshirts to jackets to vests, focused primarily on B2B. I'll cut to the chase. On March 13th, we were a company of 28 employees and about 16,000 square feet at the Dana Wart Mill in Westbrook. We had a heavy population at the time, was around 80% new Americans and new Mainers to this country, mostly from the Congo, Angola, and Iraq. We're very proud of our diversity, and that community has literally built this company with my wife and I. On March 13th, like the rest of the country, we watched as the country began to shut down. We took action. We shut our factory down, and we were very uncertain on the future. We did not know if we were going to be able to continue to produce our products, sell our products, et cetera. More importantly, how could we operate safely and keep our workers safe through this pandemic? We shut the factory down the week of March 16th. We huddled as a team and realized internally that we could produce PPE, primarily washable masks and face shields, in conjunction with Flowful, another local company here in Maine. We brought everyone back. Every single employee did not hesitate to come back to work in the middle of the pandemic. As we all can remember, March was a very chaotic time. Our workers had incredible courage to come back to work. And we continued to grow the company through the spring. From March 13th till June 15th, we went from 28 employees to 110 employees, I'm sorry. We put out thousands of masks and thousands of face shields. The number one thing to us was maintaining the safety of our workforce throughout the peak of the pandemic. We did things like implement touchless time clocks so that there was no touching of a clock on a regular basis. We centralized our entrances and exit strategy for all employees. We had staggered break times. We put up 7,000 feet of plastic to separate work pods in the factory. And we did temperature checks and mandatory mask wearing at all times while in the building, unless they were on break. On July 10th, we had our first positive case of COVID. On July 11th, we had our second. And on July 12th, we had our third. At that point, we worked hand to glove with the CDC and Dr. Nirav Shah's team to figure out what we needed to do moving forward to, one, contain the virus, find out where it came from, and how it got to our factory. We moved forward with working with Northern Light Health and Kathy Bean and the great team at Northern Light to bring in universal testing that week. We tested all of our employees, and on July 15th, we confirmed that we had 11 positive cases total factory. Shut the factory down immediately, sanitized, fogged, cleaned, and brought everyone back to work. We were down for one day. Our team showed enormous courage. Through extensive contact tracing, we quarantined a total of 21 individuals, 11 positive cases and 10 close contacts. From that point, we moved forward with the same safety precautions, improved a few things that we felt needed to be improved, like increased fogging and sanitizing. We have a full-time daily janitorial team. And on the second round of testing, we were 100% negative. We're proud of the safety measures we've taken. We feel that vigilance and approaching safety as the number one thing is critical for any business, especially ours, and that the safety of our workforce is number one.
Well, thank you, Ben. Very helpful insights. Kathy Bean, no one in healthcare will dispute the importance of delivering care in people's homes. Your teams are all about building relationships with people, and during this pandemic, your relationships allowed you to quickly see a need and find a way to meet it. Tell us a bit about how your teams stepped in to support your communities. Kathy?
Good morning. Thank you for having me today. So beginning in very early March, we, like many other companies, established an incident command, and we started talking about how this virus was going to affect our company. We looked at things like PPE, what did we have on hand, where could we get more, who was going to need it. We looked at our surge planning, so if we got 50 new patients that were all positive for the virus, how are we going to care for those people? And we also very early realized that there was going to be a need in the community for testing, and not all of the people that needed testing would be able to get to a testing site, or maybe it wouldn't be convenient for them to all get to a testing site. We started with our home care patients. We looked at triaging those and who are the people that absolutely need a visit. Only the sickest people were getting visits. Many of our patients were declining visits from nurses, therapists, and others because they didn't want extra people in their home. We developed protocols for telephonic support. So that's the low tech of telehealth. We also have had a telehealth program for about 15 years, so we were able to enhance that a bit to do some telemonitoring for people, and then telehealth with some video visits with nurses, therapists, and providers. We did a lot with managing our staff anxiety, so we started doing a daily staff call via Zoom to talk to staff about will you have jobs, because people had legitimate concerns about, okay, we have reduced volume, are we going to have a job? They had concerns about whether they were safe to be out visiting. What were we doing to protect them? So reviewing what the CDC recommendations were was really important. For our hospice patients, we continued all of our in-person care, including those in facilities. And then we developed a hospital at home program to care for patients with COVID-19. 74 patients to date were cared for by us. Most recovered with no lingering side effects, but some of them were coming out of the hospital after being on ventilators or in for a significant period of time, and they needed physical therapy, occupational therapy. Some of them needed social work or mental health evals because there was a lot of anxiety, being on a ventilator, and that is very stressful for people. So there was a lot of care that went on. All of our COVID patients at home got a telehealth device in their home where they could send us vital signs daily so we could monitor for any increase in symptoms. And we were also able to facilitate provider visits to actually see those people at home and find out how they were doing. And that worked quite well. We also programmed some questions in that we were able to tailor to meet the needs of COVID patients, so asking them about symptoms. And as we all know, the symptoms changed frequently, so we were constantly going in and editing those questions so that we were getting the most crucial questions. We had some employees who were redeployed within our system to meet needs. So some of our home health aides were deployed to nursing homes. We had occupational therapists doing scheduling, some speech therapists doing scheduling. Many of them were coming out with us to do testing. It was all hands on deck. We even had some folks that were home sewing cloth masks that we could share with our patients and our staff in order to help with this effort. And then some employees did choose voluntary furlough. Nobody was furloughed unless they wanted to, but some people preferred to take their time off rather than know that they were constantly on call. So surveillance and testing really was our big change, something that we had never done, and we realized that this was going to be a significant need. It started in the Portland homeless shelters, where there were several people that were quarantined or isolated due to being COVID positive or having significant exposures. And these people were in situations where they weren't able to access any medical care. And there were frequent calls to EMS and visits to the emergency department. And so we were approached about how could we assist. We started the very next day with a team going in to do symptom surveillance. So they were doing pulse oximetries, temperature checks, asking them about symptoms, and then making referrals as appropriate. If people needed a higher level of care, they were sent for that. Many people were referred for COVID testing. And then there were other referrals that came about because we were seeing these people. So people that didn't have their medications, we were able to connect them with providers. People that needed wound care, we made referrals to the wound clinic. So a lot of things were going on with that surveillance testing. We did some surveillance at some congregate living sites, some assisted livings that were having outbreaks and needed some help. And then lots and lots of testing. We did testing at the shelters in conjunction with Mercy Hospital a few times. We've been to many congregate living facilities, businesses such as American Roots and others. And we've tested 2,500 people to date. So that's a lot of noses to swab. And then the state came out with some recommendations that businesses and organizations, particularly congregate living, assisted livings, should partner with a home health agency and make sure that if they had an outbreak, there was a plan in place for folks to come out and get them tested.
Great. Well, thanks, Kathy. Shelly Hayden, we've certainly learned that skilled nursing facilities have vulnerable populations that are highly susceptible to this virus, and Maine is no exception. Your teams were very well prepared, yet outbreaks struck in 2 of your locations. Describe how the outbreaks unfolded and some lessons learned. Shelly?
Thank you, Dr. Gilkey. Good morning, everyone. It's a pleasure to be here with you today. Continuum Health Services has facilities in 3 counties in Maine, and we serve over 700 seniors, providing everything from independent living to nursing home to short stay rehab. We have about 800 employees across the state. Like other people discussed, we spent a lot of time preparing for COVID to come to our state and ultimately preparing for an outbreak in our facility. And we had, despite all that preparation, we had 2 buildings have outbreaks on the same day. May 13th, we had a facility in Androscoggin County and one in York County have positive cases. In one building, it was a staff. In another building, it was started with a resident. In both of these cases, well, in all of our cases, in all of our buildings, we have been practicing very low threshold testing. So initially, the belief was that the virus primarily affected the respiratory symptoms. So there was a lot of discussion about cough, shortness of breath, fever, but it became clear very quickly from information coming from other countries that this was not just a respiratory virus and that there were a wide range of symptoms. So we continually updated our screening for our staff and our residents to make sure that we were detecting cases early. In the one resident, in that case, it was a patient who had come from the hospital, and we were doing surveillance in the period after her admission. And she had a low-grade fever. It was 99. No other symptoms, and we swabbed her and got a positive. In the other case, which I'll talk a little more extensively about, we had a staff member who called complaining of muscle aches. We tested her, and she was positive. So we began by testing everyone that lived on the unit that she worked on. We also tested all the staff that worked on those units. And then we folded in any other known connection to her that we had. We found in that first initial round, we had 2 staff that were positive. It was a friend of hers and a sister who worked on the other side of the building. And we found our first positive resident as well. By the end of our initial round of testing of staff, we had 18 staff that tested positive and 4 residents that tested positive. And at this point, still, the only person with any symptom was that initial person who had the muscle aches. Nobody else had symptoms. We had 17 people walking around our building, 17 staff with absolutely no idea that they had COVID. Of those 18 employees, 8 of them throughout the whole 14-day quarantine never developed a symptom, and 10 went on to develop mild to moderate symptoms. We had a couple people with intermittent cough, somebody with a sore throat, somebody with nausea and diarrhea. We had a staff person that had 1 episode of vomiting, but she confessed to me she'd eaten a whole box of Slim Jims the night before and thought that might be the real culprit, not COVID. We had somebody who just had a body rash, a strange body rash that she'd never had before. So it was just an array of symptoms, and mostly mild. We had 1 person I would describe as having moderate symptoms. He had more shortness of breath, fatigue, chest discomfort, but no residents and no employees ended up needing hospitalization. All our residents graduated from our COVID unit. 2 weeks later, we had set aside a special unit for residents to go to should we ever have any positive. It was ready to go. It was sectioned off, had its own employees and its own entrance, and that's where those residents went. And the staff, of course, were put out of work. In addition to those 18 staff, we also had 4 more staff that needed to be removed from work because they lived with one of those 18 staff. So we initially had 22 people on the same day gone from our workforce. Then we continued to do ongoing surveillance, testing staff and all residents another 2 times within the next 14 days to ensure that we didn't have any more COVID that just didn't reveal itself on that first test. After that period, that initial 14-day testing, we had no one else. And then we started an ongoing tiered surveillance. And what that entailed was really thinking about who was high risk to if they had COVID and were coming in our building. And so that would be our providers, our physicians and NPs that were going to other buildings and seeing other patients, new employees, staff going out on vacation, are coming back from vacation, I should say. And then our COVID unit staff, we wanted to make sure to routinely test them for at least 2 weeks past when they stopped working on the COVID unit. In that surveillance, we found 2 more positive staff and 1 more positive resident, again, with no symptoms. We then went on to complete our 28 days without any new cases, and we got our independence on July 4th when CDC closed our outbreak. So as prepared as we were, there were some things we were not prepared for. We were not prepared for losing 10% of our workforce. We lost several people to fear and anxiety. We had a few staff that had come to us prior to the outbreak. They had had conversations with their primary care physician or their spouse's primary care physician. And the plan was, once we had a positive person in our building, that they would take a leave of absence. So we were prepared for a few people. But what we weren't prepared for were the number of people that felt very fearful and needed to take leaves or quit altogether. We have continued to do ongoing testing, and that has created a lot of anxiety in staff. Some handle it very well, and others get very anxious, almost to a panicky level, about having the test itself, about what the results are going to be. And we've lost some staff because of that as well. We've had new employees, once they find out they have to be tested routinely, that opt out of working in senior care. If I could offer anything, I would say plan ahead, have a plan, share it with your staff, educate yourself. If you're well educated, then you can better support your staff and help allay some of those feelings of panic and fear. Have your resources ready. Know all of your staff connections prior to your outbreak. That's a little difficult in the middle of an outbreak to be trying to figure out who's best friends with who's in a relationship. Have that information and have it handy, because you won't have time for that in the middle of things. Anticipate any special language or cultural needs. Catholic Charities has an enormous amount of resources in multiple languages that could prove to be very helpful for your folks that English is not their first language. And really the key to success is just keep your foot on the gas. Reinforce appropriate mask use now, social distancing now. Talk about it with your staff so that everyone feels a little more prepared if this ever hits your doorstep.
Awesome. Well, thank you, Shelly. Very useful information. Dr. Jarvis, testing continues to be a hot topic. Businesses want more access to ensure their employees are safe to work. And with the reopening of schools and college campuses, the need for more testing just keeps growing. What are you seeing out there?
Well, thank you, Ed. I will just start off by saying I am just humbled by the informative, inspiring, and uplifting stories shared today. And I wish that I had better news and could be as inspiring as they are. I will use it as a dovetail into local recent events, which we have seen that this virus is still out there, and that if we are not following the governor's executive orders or the guidance given to us from the various departments and agencies at the state level, it just takes one individual to then spread the disease through an entire community, which then takes us right into testing and how can we do testing. Right now, the CDC is recommending against using the rapid test for asymptomatic individuals, that the accuracy of that test in people who don't have symptoms. And so if you are going to contract with a company to do testing, please make sure that you know what test that they are offering to you. It is recommended that for asymptomatic and screening purposes that you are using a full PCR test. It's also important to our schools and our parents. Many of our universities are now insisting that at least the original test done to start campuses is a PCR test. And so our parents and students will have to make sure that that's the test that they are getting when they look at it. When we look around nationwide, testing result delays are becoming the norm, with some areas seeing that all tests are taking 1 to 2 weeks for turnaround time. Most of us in the clinical world would say that a test that comes back after 72 hours has very little clinical utilization for us, because in that intervening time frame, it is quite possible that somebody became infected and you're using a test to kind of say that they're safe to be out in our community, and that may not be the case. Here in Maine, we are seeing similar delays. Unfortunately, we are held to the same things that the rest of the country is seeing, where we continue to see supply chain issues, where we are having issues with getting those reagents that the machines use to run those tests getting those swabs that we use to collect the specimens and having that transport media and transport tubes to transport the sample from the testing site to our laboratories. And so we're seeing delays here in non-clinical situations of 48, 72 or more hours, sometimes a week or more. So when you're looking again to explore using testing as an option for you, you do have to call around and find out what their turnaround time is. Until there's more readily availability of PCR testing, symptom screenings is definitely the way to go for protecting our students, our employees, our customers, asking whether or not they are feeling unwell, and if so, having them remain home or out of our businesses. Whether or not you do that with temperature taking is really an individual decision. In many areas, asking to do temperatures is one, a little bit restrictive, and two, may result in some false positive things. I get asked this all the time, where can I go to get tests? The best way is really to reach out to your local facilities. Northern Light Health has a great resource page right now, where the link is right there on our website, and that information will be shared with you that will actually guide you through the process of where you need to go for testing if you're symptomatic, if you're having a pre-procedure, or if you're asymptomatic and need to have something else, or to one of our business partners so that we can help businesses as well. And with that, I think, Ed, we're going to turn it over for questions.
Great. Well, thanks, Jim. Yeah, so let's focus on your questions. I will group similar questions together so we can address as many questions as possible. So the first question is for Shelly and Ben. How was the infection first recognized in your environment? And what I'm really seeking to get at here is, Shelly, you described a whole host of different symptoms that people had, and some are kind of like these very general type of symptoms. So trying to get at, like, how did you get tipped off to pay attention and say, we should probably test for COVID? That's what we're looking to try to get at. Shelly?
Well, I think we had really paid attention to a lot of the information coming out of other countries about just the myriad of symptoms that are out there. So if anybody was experiencing anything out of the norm, whether it was nausea, vomiting, and diarrhea that wasn't normal, a cough that wasn't normal, body aches, fatigue, we were testing staff. So we had routinely been testing staff at a very low threshold for unusual symptoms. So when that staff, and we had educated staff to let us know whatever it is so that we could make a determination. And so when that employee called and said, my muscles are really aching, and by the next day she had a pretty significant headache too, that was what prompted the facility to take a swab and send it off to the lab.
Mm-hmm. So it sounds like being armed with contemporary knowledge as it was very, very helpful. And then it also sounds like having a low threshold for this whole collection possibly being COVID related. Okay, go ahead, Shelly.
Oh, absolutely. And our environment, in some environments, the impact is different. In our environment, we had a medical advisor advising us through all of this, and the impact is so significant. Should we have an employee, we have hundreds of residents counting on us, and the outcome for them, as we've seen in other states and other countries, can be pretty dismal. We had to have just a very low threshold. We did a lot of tests that were negative. There was a joke in the buildings that if you sneeze in a continuum building, you get swabbed. But we really felt we had to take that approach given the population, the vulnerable population that we serve.
So I'll add to what Shelly's saying. You can remember the timeline that Shelly shared with us. Recognize that the prevalence, the number of cases in the state, if anything, has increased somewhat from the time that Shelly was dealing with the outbreaks. So we still need to have a lot of preparation in place and low threshold for trying to figure out what's going on. Ben, I'm going to ask you the same question, but maybe in a slightly different way. Refresh for us like how it was first recognized in your environment as well, and really looking for like what kind of tipped you off. But take it a step further. You were mentioning early on the connection to the main CDC, Dr. Shah and his team there. Take that a step further and help us to understand, do you have any tips for contact tracing that you learned along the way? Ben?
Sure. So we obviously scaled up our own business, and we made a decision very early on in the interviewing process of new employees and current employees that we wanted to know where each individual, what their living situation was. So we know where a husband or a wife or a child works, how many people live in the house, so that we were able to track. When we had our first episode, we knew that this individual lived with another individual who worked in a facility that had outbreaks. So we were able to trace that back directly, which I thought was critical. We also had a policy, Dr. Gilkey, that anyone who, our shift starts at 7:45 in the morning, anyone that woke up and had any type of symptom, nausea, vomiting, diarrhea, headaches, body aches, and were concerned about it or even had those, they had unlimited paid sick days, and that's still the case with our company. If those things continued after one day, we required that those individuals get tested before returning to work. We've had that policy from the beginning, and I think that's helped in a big way for us to identify. Unfortunately, as we all know, we temperature check every day. We temperature check the day that Kathy and her team came in, and we had positive cases. So it's not, it's a very difficult thing to do, but I do think the more you can know about where your workers, what their home life is, and not in an invasive, violating privacy manner, but you can understand what their background is and where they live and how they interact with their family members, the safer you can be in the long run.
Well, it sounds like really knowing your employees made a big difference. Yeah. Well, thanks. Dr. Hammond, the next question from our audience I'm going to ask you to weigh in on, and it actually has a couple of components, so just bear with me, but you'll see the theme. What do you think makes the biggest difference to keep the virus from spreading? Do you think that the mask really made a difference, or the social distancing, shield coverings, hand washing?
Yeah, so there are a lot of questions in that paragraph. I think number one is hand washing. So we know that we wash our hands to prevent the spread of every germ out there, colds, flu season, all of that. And so if you wash your hands, then you don't have those germs on your hands, and COVID is no different than those other viruses. So it starts with hand washing for everybody. A lot of us joke that because of COVID, we're actually become a little bit cleaner and more sanitary with things that we never should have been doing to begin with. And that kind of plays into the masking. So we teach our kids to cough and sneeze into their elbows to prevent the spread of coughing and sneezing. That was something that we knew to teach before. And now with COVID, it's just become more and more important because of a new virus that is unknown. And unfortunately, the mask protects for that instance when you didn't cough or sneeze into your elbow, or you are breathing or talking really fast, or have the aerosol, or you've been exposed. As Ben said, you may not have a fever and you may feel fine, but you might have picked up an illness, a virus of any type, whether it's COVID or another one, and you're still able to transmit that to other people before you know you're sick. So the mask really protects other people from sharing your germs, as well as from you receiving others. So I would stick to those two as the top two.
Yeah, great. Dr. Jarvis, I'm actually going to ask you to weigh in on that same question. You've been immersed in this, throughout. So, I think this messaging can't be overstated, if you will.
Yeah, and I agree, Ed, and I'll use the same analogy I've used on these webinars before. If we think about car safety and the decrease in deaths from automobile accidents, the first thing we instituted was seat belts. If you remember, initially seat belts just went around your waist, then they added the shoulder strap, and we've seen a remarkable decrease in injuries and deaths just due to those efforts. Added to that is airbags, and when we added airbags, we decreased the trauma and deaths even further. Similarly, when we're talking about this, as Dr. Hammond says, washing your hands is paramount to any good infectious control. Adding social distancing certainly made a much bigger impact for us, and then masking is additive to that. Those face coverings are like the airbag. They just add another layer of protection for us. When we look at the early hotspots around the country, particularly Washington State and New York State, when they instituted social distancing and masking requirements, their rates plummeted and New York continues to now be actually one of the lower prevalent states in the country, and they continue to enforce social distancing and face coverings in all of their areas. And so they made a dramatic difference, and we need to continue to do that and push that. As I said before, it only takes one business in your community to decide to not follow the governor's orders or those guidance from the CDC or other government agencies to all of a sudden have your entire community threatened to be shut down again because of an outbreak. If we all are in this together, we will all get through this together, and it really is that all that's important.
Great, thanks, Jim. And so I'm going to take the liberty of being doctor number 3 that's going to weigh in on this. I can't emphasize how important all of this is. The way I've learned about the coronavirus is it's a very simple biologic system. It does one thing really well, and that's infect people. And every single opportunity the virus gets to infect someone, it will be successful to do that. So if you think about that in very simple terms, every time we're exposed to the virus, or anyone's exposed to the virus, they will become infected. It's not that they won't. And recognizing that it's thought that maybe as much as 30% of people who are spreading the virus around are asymptomatic at the time. So we have to take that into consideration. So it's not like so-and-so's coming over your house and they probably don't have it. You really have no idea. So I think those are the things to pay attention to. I would suggest everybody move well beyond the politics of all of this and recognize the simple principles that Dr. Hammond and Dr. Jarvis shared with us are to be followed. That's the way we're going to actually keep Maine with these fantastic, relatively fantastic statistics compared to the other 49 states. So thank you all on that. The next question I'm actually going to also direct towards Dr. Hammond, and I'll read it. I think it will flow best that way. What guidance or best practice can people offer regarding the possibility of having a household member of an employee who is told to isolate but has no symptoms? For example, a school-aged child is told to isolate but has no symptoms. Can the rest of the household return to the workplace? That's a tough question.
That is a tough question. So I think what you're saying is a school-aged child is asked to isolate, and so mom and dad need to go to work, something
Yeah,
of
I
that
think that's the bottom line of
situation.
it. Yeah.
Yeah. So, I think those things we're going to see more and more of that, certainly as the schools are doing different things and different types of learning and different types of testing. So if you are going to the grocery store or you are going to an environment where you're not able to socially distance, certainly that's not isolation. And so that is a risk. I think as Dr. Jarvis, articulated earlier, it's the layers. So if you have to go to work and, we should all be 6 feet apart. So we start with the social distancing. So you're going to wash your hands to limit your carrier ability. You're going to stay socially distanced 6 feet apart from your coworkers. You're going to wear a mask while you're there. Then you're doing everything you can to limit that. So I don't feel as though a statement like a question like that has one answer. I don't think we can say, no, everyone in the house must stay home, given that it was just in isolation. If we're talking about a positive case, that would be completely different. But when we're talking about isolating to protect, we're talking about other layers to reduce the spread, then I think we have to be mindful of all the different things we can do to diminish our ability and our exposure.
Thanks. Thanks. And, I think it's all about risk mitigation to whatever degree, recognizing that being at home, isolated, with no contact with the outside world, you pretty much are at zero risk. And everything else beyond that just layers on small increments of risk. And then big parties 1 foot away with no mask, well, you'll just escalate the risk tremendously, as we've seen across the country. So thanks, Sue Ann, for that. Ben, the next question's for you. You had mentioned during your part of the presentation that you used a fogging in your environment. Could you tell us a bit more about that, how you came about it, and where perhaps might be resources to look to doing that?
Sure. We and I'll look up as soon as I'm done talking. We use a local company out of Biddeford. They come twice a week. We actually implemented that following the outbreak because we learned more about it. And since then, we've had repeated negative testing, knock on wood. That person comes in twice a week. They spray a chemical that is known to kill pretty much everything in sight. It's not necessarily toxic to the individuals when you're in the room, but we obviously do it at night. It kills virus on surfaces. This is on top of our janitorial team that cleans all day long throughout the workday, all workstations, between breaks, off breaks, and when someone removes themselves from a workstation. It does not affect the fabrics. We obviously work with a lot of fabrics, so and it does not affect computers as well for technology purposes.
Great.
I would highly recommend it, and it's very affordable.
Great. Well, thanks, Ben. That's very useful info. Next question, Shelly. Tell us more about the fear and the underlying anxiety, first of your staff, then the residents and family members as the outbreaks were unfolding.
As far as family members are concerned, each of the administrators in the building started long before there was an outbreak, doing regular communication with families, written communication, conference calls weekly. During the outbreak, there was more communication and more attendance in those conference calls. So just really providing them with a lot of information because of course in nursing homes and assisted living, some visitations aren't allowed. We've just recently been allowed to open to outside visitation, which has helped tremendously. As far as the staff is concerned, we just, each building handles it a little bit differently, but a one-on-one with managers and department heads. We use constant contact for email communication, and in every email communication, we add the employee assistance program number and the frontline warm line number, which is an agency that that DHS and social worker and the Maine Psychological Association came together to provide for people who are clinicians or EMS personnel that can call 7 days a week, 12 hours a day for support, because our staff are not immune, obviously, to the anxiety and the stress of caring for people during COVID or in anticipation of COVID. So those are some resources that were available. And then some people sought individual EAP as well.
Great. Well, thanks, Shelly.
Sure.
Kathy, Did your staff have concerns about going into hotspots and then going home? That question is fairly similar to the one about people coming and going to work and their home environment. Could you comment on that?
Sure, we did have staff that had concerns about going into hotspots and going home. I myself was out in several outbreaks testing, and then you really have to be mindful about what do you do when you get home. Simple things like not wearing your shoes into the house and then changing right inside the door so you can get into the shower. But we were also, constantly reassuring staff that the PPE they had was within CDC recommended guidelines, and that, we were providing them everything that was recommended to keep themselves safe. But that was a very common thread on our daily calls with staff, was concern about the safety of their families at home.
Great. And Kathy, you make a point that I think doesn't get emphasized enough. It's the idea of the surfaces that we walk on and how we can pick that up on our shoes. So if you think about a respiratory virus, it's in the droplets, as we know, and the heavier the droplets, the quicker and the shorter distance from our respiratory tract these droplets get onto the floor, and then it's so easy to pick them up on our shoes. We don't have studies at this point to know how long they might last there. We've heard all sorts of different issues related to surfaces and people delivering packages to our homes and all of that. But I think that's really worth paying attention to, the shoes. Okay, having said that, the next question, Dr. Jarvis, this one's for you. What is the best way to try to get the germs out of the air versus the surfaces?
The best way would be to not have them in the air, and that's where we talk about why face coverings are so important, because it keeps that moisture that comes out in our breath from getting out into the air. And so that's the paramount number one thing. Number two is, of course, understanding why we talk about social distancing, because our breath only goes so far, but the more we project, the more we talk louder or sing, we can project those particles even further. So that's the reason why that distance. So then we're talking about more when we're talking mostly about enclosed spaces. So how do you protect your employees or your students and staff members, as well as your customers and clients? And that's to make sure that you have good ventilation systems. And so whatever your HVAC system is now, you should make sure that it's working as efficiently as it has been before, and keep it up to date. We do know that having good airflow from the outside certainly helps to change over the air content. And so now, while the weather is nicer, being able to keep windows and doors open is certainly a way that you can help mitigate the amount of viral load that is actually out there in the air. But that's not going to last much longer. Unfortunately, our days are getting shorter, which means that winter is around the corner, and we will be indoors more, and that is a concern for all of us. So that's why we have to keep up our diligence of making sure that people who are ill do not come to work or do not come in as customers of ours, keeping students home if they are not feeling well, and then having everybody wear face coverings out in public places. Those are the things that we're going to do to help prevent the spread. Unfortunately, we can't change the air in a moment's notice. Even in hospitals where we take huge precautions to do that, we still know that time is of essence when we're talking about changing over the air. So the better thing, just don't let the virus in your workspace at all.
Okay, great. Thank you, Jim. Ben, next question. Tell us more about informing the staff about protocols and how you may have enforced them.
Sure. So we obviously, before we brought the staff back, we had to huddle both with our union representatives who represent the workforce. We formed a safety committee, a labor management team. Our CFO in particular headed it up from the management side, and our operations person, who's my wife, along with two of the union officials as well as floor leads, to discuss what did we need to do to, one, make sure people were not spreading the virus while they were here, and two, how do we prevent the virus from coming in. So we put in place, based on the CDC guidelines in late March, and those continued to evolve, those institutions of social distancing, of temperature checks, of mask wearing, of health check-ins. We actually did a health check-in at the beginning of each day. Our administrative office manager would check each person in, ask them how they're feeling, do they have any body aches, have they been in contact with anyone, and then they would be allowed to come to work. I do think that that is something that you have to follow, to your point, Dr. Gilkey, science, and follow what the CDC is telling us, and don't dispute it. Set aside your opinion and realize if you come to our factory, and Kathy has been to our factory, there are yellow X's in every part of the factory, and if you're standing still and you're not standing or sitting on one of those yellow X's, our floor leads are assigned to remind you that you need to be at one of those spots.
Awesome. Yeah, thanks, Ben. The last question for our panel, I'm going to direct this to Dr. Hammond, and I'm only going to give you 30 seconds to answer it. So tell us about the 7-day positivity rate in Maine that has been under 1, so pretty much one of the best in the country. What does it mean? And equally importantly, can we do more activities with others because the risk seems so low?
30 seconds for that? Oh my. The 7-day rate is because we're doing what we're supposed to be doing with the masks and the social distancing and the hand washing. But I would say, as Dr. Jarvis said earlier, not to let our guard down. There are a lot of things coming and changes coming and seasons coming. So we have to continue to be diligent to protect ourselves and our community.
Perfect. Wow, 30 seconds too. So thank you, panelists. This was very informative. Thanks so much for sharing your experiences with us. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information and insights to collectively and safely reopen Maine. We hope you have picked up some useful tips to prepare you for a potential outbreak. Next week, the new school year is upon us, and with it, new demands, new routines, and new worries. Join us on August 27th at 11, and let's figure it out together. Our topics will include support for teachers, parents, and students. We will send you the link along with the topics for August 27th. We encourage you to share the invitation with your friends, colleagues, and others who might benefit from this information. By working together, we will keep Maine safe. Thank you and have a good afternoon.